Good afternoon, everyone. Welcome to this HCC Gecko session, which is hosted by the Gastro Foundation Association with Project Echo, University of New Mexico. These sessions are held every week on a Wednesday. The chats will be open for questions throughout. So if questions, just please put them on the chat. Alternatively, after each speaker's spoken, just you can raise your hand and we can have a discussion. So my name is Marc Bernon. I'm going to be speaking on the extended role of TACE in sub-Saharan Africa. Professor Edward Jonas is going to be talking about HCC in pregnancy, and Dr. Brian Masoy is going to be presenting an interesting case that we've just in the process of managing. Just going to share. So, can you guys see that?
Yes, we can. Go ahead.
Okay, thanks. Okay, so like I said, I'm going to be speaking on the extended role of TACE, specifically in sort of resource constrained areas. As we know, HCC in Africa is associated with a high incidence of hepatitis B infection, and we have a lot of young patients. 50% of the patients with HCC are less than 50 years old, and a high proportion of the patients are non-cirrhotic. And because many patients don't know that they have hepatitis B and don't know that they are at increased risk, patients often present with advanced diseases. They're not in screening programs, and there are often associated comorbidities such as tuberculosis and HIV that make this disease very different to HCCs that are picked up in world and developed countries. So if you look at how patients present and the treatment options, patients in screening programs, and that patients who should be in screening programs are patients with cirrhosis and chronic hepatitis B, generally present with earlier stage disease. And like I said, patients with symptomatic tumors generally present with advanced stage disease. So if we look at the treatment options, the three curative intended treatment options are liver transplantation, liver resection, and local ablation. And then we have the treatment options for the more systemic or for the more advanced stages of disease, which are generally considered palliative, which are the transarterial therapies, particularly TACE, and systemic therapies such as immunotherapy or the tyrosine kinase inhibitors. So TACE is recommended, and I'll go through the Barcelona Liver Clinic staging system. So TACE is recommended for patients with intermediate stage tumors. There's different types of TACE. You can do conventional TACE with lipidol or TACE with drug-eluting beads, and in that setting, it's a palliative treatment with the goal of getting some form of tumor control to prolong good quality of life and control symptoms. And it can also be used as a bridging or downstaging treatment to allow one of the curative and intended treatment modalities. So this is the updated BCLC staging system from that was published. It's actually in press in the Journal of Hepatology. And if you look here, the role of TACE is actually quite limited to some patients with intermediate stage disease. So they've divided the intermediate stage disease into three. So patients with well-defined nodules, preserved portal flow, and selective access. So that means that you can access the arterial system are candidates for sort of palliative TACE. And then down here in the curative intended group, they say that TACE or TEG can be considered, and that's as part of a downstaging or bridging therapy, or if there's a failure or or non-feasibility of one of the curative intended treatment options. The problem that we have in sub-Saharan Africa is this advanced stage group where the recommended treatment is systemic treatment, and the first line is atezolizumab and bevacizumab, which is immunotherapy, or tyrosine kinase inhibitor. And the problem with that is that they are generally quite expensive and not available. So this is a group of patients that we've struggled to treat because we don't have any option for them. And this is the group of patients that we've started treating with TACE. And I just wanted to go through a recent publication from our unit that looks at this group of patients and how they've done. So basically, it was a retrospective analysis of close to 600 patients treated over a Groote hospital over quite a long period of time. 71 patients were treated with TACE, and 54 of these patients had BCLC stage C or D disease. So they were outside of the BCLC criteria for TACE. Systemic treatments, like I've mentioned, I've mentioned that the systemic treatments are not all available. But if you look here, the survival was better for the intermediate stage disease than it was for the BCLC-C and BCLC-D patients. But we looked at whether there were some factors that might predict better survival in the patients with more advanced disease. And we identified gamma GT, AST, and the presence of portal vein invasion as independent predictors of survival in patients with more advanced disease who get TACE. So if you look at the patients in this cohort who were just treated with best supportive care versus the small group that received a tyrosine kinase inhibitor and those who received TACE, the patients who were treated with TACE had improved survival. And then if we look, if we divide patients into those who had a gamma GT less than 800, AST less than 250, and no portal vein invasion, you can see that there was a survival benefit. This was for the stage C patients, so patients with more advanced disease. So patients who meet those criteria seem to get a benefit from TACE, whereas patients who had a gamma GT of more than 800 or AST of more than 250 or portal vein invasion with more advanced disease don't seem to benefit from TACE. So this is a way of identifying patients with more advanced disease who may benefit from TACE. So apart from the palliative treatments, the other indications for transarterial therapy are the bridging therapy for patients who are on a transplant list, and there's quite good evidence to support offering TACE to patients who are likely to wait more than 6 months on a liver transplant list. And then conversion therapy, which is therapy that's intended to reduce tumor burden so that a patient becomes amenable to curative intended treatment, whether that be transplant or resection. So generally, transarterial therapy, generally TACE has been used for downstaging. There is some evidence to support that TARE may be better, but it's more expensive and not as widely available. And in places where there is systemic therapy, the combination of TACE and systemic therapy seems to be better at conversion than just transarterial therapy. So the rationale for bridging therapy while patients are on a transplant list is to try and decrease dropouts. In the US, 22% of patients drop out on a waiting list, and half of those are due to tumor progression. As I mentioned, bridging is recommended if you expect it to be on a waiting list for more than 6 months. And it's been suggested that patients who have a good response to bridging therapy prior to the transplant have a lower post-transplant risk of recurrence. So it's been shown that the pathological response to any pre-transplant local regional therapy predicts outcome after liver transplantation. So this study was a consortium of a consortium of liver transplant units in the US. All patients older than 18 transplanted over about an 11-year period for HCC received bridging therapy were included, and patients were divided into those who had a complete pathological response and those who didn't. So there was quite a large number of patients included in the study. The median age was 59, a majority male. A majority of patients had hepatitis C. The MELD score was quite low, 12, the median MELD score, and 60% of patients had TACE as a bridging therapy. 11% had TACE and thermal ablation, and 15% just had thermal ablation. 23% had a complete pathological response, and 77% had a partial or no pathological response. So patients who had a complete pathological response to bridging therapy had better overall survival at 1, 3, and 5 years. So they also had a better AFP response. It was more likely if patients received ablation and had smaller tumors, and it happened to be more likely if patients had hepatitis B. So one of the issues at the moment is that current liver allocation systems and the BCLC system really focus a lot on morphological criteria, but there's increasing evidence that that we need to look more at tumor biology and treating patients with local regional therapy before we offer them one of the curative intended treatments is a way of assessing tumor biology. So morphological criteria are crude, and they exclude a lot of patients with good tumor biology and also include patients with bad tumor biology. So the use of a neoadjuvant therapy may also apply to potential resection candidates, and that's going to come into the case that Brian's going to present later. So some of the other factors that we can look at, and this is something that's been suggested when we allocate livers, is to not just look at the morphological criteria, but also to take into account markers of tumor biology, such as microvascular invasion, poor differentiation, increased AFP without a decrease after some form of local regional therapy, a positive FDG PET, no response to local regional therapy, and early recurrence within 3 to 6 months after local regional therapy. So these are factors that we need to factor into our decision making when we're deciding to offer, things like transplant and resection that carry a risk of morbidity and mortality, especially in patients who have cirrhotic disease and portal hypertension. This is another paper that was published from our unit that's just discussed how we should consider increasing transplant eligibility in sub-Saharan Africa. There is a downside to doing transarterial therapy, particularly in patients who might be getting a liver transplant, and it's been shown that repeated TACEs may increase the risk of hepatic artery thrombosis after transplant. Systemic therapy, there's lots of trials on the go looking at systemic therapy as role in downstaging and bridging therapy. The advice is that, like I said, bridging therapy should be offered if the wait is longer than 6 months. This is the American guidelines. They do not advise any specific form of local regional therapy. TARE may be associated with reduced progression and dropouts, and that immune checkpoint inhibitors must be stopped 3 months before transplant. Downstaging, they don't recommend how it should be done, but patients downstage into Milan criteria have a 5-year survival of close to 80% following transplant. So in conclusion, TACE can be used outside of BCLC criteria. I think it's becoming more clear to us which patients are likely to benefit from this approach. There's increasing evidence that a response to local, regional, and systemic therapies before surgery is a marker of good biology and is associated with better outcomes. And there's also good evidence to support downstaging and bridging therapies before transplant. Thank you. So I don't know if there's any questions. I just want to go to the chat.
Marc, I couldn't see any questions in the chat.
Yeah.
Just in terms of extending the indications for for TACE beyond the guidelines, what
Mm,
obviously your outcomes are not going to be as good as the reported 22 months
mm.
or 24 months for within criteria. But what would be an acceptable survival to have as a cutoff in patients where you extend the guidelines?
Um, so I think it's quite difficult to answer that. We know that accrued scare, the average time from presentation to death when patients present with more advanced HCCs is 60 days. And I think you don't want to offer treatments that really don't have that much effect on survival. So I would say I think we should probably be looking at doing it in patients who, I mean, I'm just sucking this number out, but I would say you probably want to be doing it in patients who are going to survive longer than 6 months. I don't know if you agree with me on that.
Yeah, no, I think one must accept that your results are not going to be as good as
Mm,
based on the current criteria as within the criteria. But the reason why we use TACE extensively and outside of guidelines is also because we don't have any systemic therapies and
mm,
not even sorafenib or lenvatinib in the state available. And if you look at the survival advantage of basically all the drugs that are out there at the moment, and if you look at the randomized controlled trials, that even for the doublet chemotherapy, the atezolizumab and Avastin, that your advantage or your survival advantage is probably not exceeding 10 months. And
mm.
if we use that as a cutoff, I think one is quite safe because the alternative would only have offered you that in terms of a median survival. So that's maybe one thing that one can use to make sure.
I think that one graph was quite like useful in that study that was published showing in the advanced stage group who had a low AST, low gamma GT, and no tumor invasion into vein, there was definitely a survival benefit in doing TACE. So, that group of patients do benefit. But I think there's, like if you've got massive amounts of portal vein invasion and tumor all over the liver, there's a group of patients that don't get benefit from it. So I think we need to try and pick the patients who are most likely to benefit.
Okay, thanks, Mark.
And then like also before surgery, by doing TACE and using it as sort of as a neoadjuvant treatment, it allows you also to try and select out patients who may benefit more from surgery because, operating on a patient who's cirrhotic, who's got portal hypertension is risky, and you only want to do it if there's going to be good outcomes. And doing TACE and seeing if the alpha fetoprotein drops and if the tumor does responds and there's no new lesions is a good way of assessing that patient might actually benefit from surgery. So I think that's another role, like I mentioned, sort of almost as a neoadjuvant treatment before surgery. So there's a question. Would this also apply to patients with fibrolamellar carcinoma? I currently have a young patient with a good performance status, BCLCC. So it's a good question. So we've actually had a patient with a fibrolamellar carcinoma that we treated with TACE, with a good response. And if there's actually a paper that's been published in the last year or so, it was from one of the American organizations on the management of rare liver tumors. And in those guidelines, they also recommend the use of TACE as a downstaging therapy, potentially in patients with fibrolamellar carcinoma. And the rationale is that it's a hypervascular tumor, and there's no systemic therapy that really works apart from stuff that's being tried in trials. So there is evidence to support using TACE in patients with fibrolamellar carcinoma. So yeah, I mean, I think we've done it, and I think it's a good. Although it's not in the guidelines, there's evidence to support it.
Yeah, I think, Mark, if you remember, I think we published on this 2, 3 years ago.
Mm, yeah,
Our
yeah,
cases
yeah,
and systematic review of TACE in fibrolamellar cancer, and it's certainly used.
yeah. And they've
Although
also used. I know the guys in Newcastle in the UK. did tear on a patient with a very good response and then resected the patient. So a lot of people have used it as a sort of as a downstaging treatment. Yeah.
Probably too few patients to create really sort of well-established guidelines.
Yeah. Yeah. Oh.
I don't see any other questions there now. Okay. Shall we just continue?
Yeah, let's carry on.
Let me just see if I share the right screen here. Can you see my screen?
Yes,
Yes.
Okay. Sorry, I'll just move something here. All right. So this is a topic that we've actually discussed before in this meeting, I think 2 or 3 years ago, where we can give you some updated data and more cases that we have treated in our institution. So if you look at malignancy during pregnancy in general, it's estimated that 1 in 1,000 pregnancies annually there will be it will be in a patient either with a tumor or a tumor that is present during the pregnancy, or a patient that have had a tumor just before, or to get a diagnosis after the pregnancy. If you look at the histological types, it really matches the incidences of the different tumors in non-pregnant women at a comparable age. And most of the data actually comes from high-income countries, and this is the list sort of compiled in terms of decreasing frequency. So not surprisingly, breast, cervix, ovary, thyroid, melanoma, and then the hematological malignancies. There seems to be an increase in the incidence of the diagnosis during pregnancy or associated with pregnancy. This is just a Danish study that shows quite a steep increase from the 1980s, now almost doubling up down to 2006. The study was published in 2013. And you can see here that it was mostly due to an increase in breast cancer and melanoma, because there was a decreasing or stable and then a decreasing incidence in terms of cervical carcinoma. So this, and you saw there that HCC is really not even featuring on that list, and there may be a number of reasons for that. And that is that the incidence rates of HCC in high income countries, they're relatively low. And then the median age of diagnosis in females is between 65 and 69 years. That would fall outside of the childbearing years. And also as far as the cirrhosis and the risk factors for cirrhosis are concerned, that they have an impact on fertility in both genders. So patients are less likely to fall pregnant being cirrhotics, and also if the main etiological factors are mast and alcohol overconsumption. So it's reported that 70% of females with cirrhosis will experience amenorrhea. And even in males, there's a number of factors that will make them less fertile. And then mast creates a metabolic and hormonal environment that's also detrimental to reproductive function. And in males, again, some problems that may create problems. Alcohol overconsumption, especially in females, is well known as making females less fertile. So I think those put together, especially the low incidence rate, the older age, and then the impact of the risk factors and cirrhosis on fertility, make it less common. So it's different in sub-Saharan Africa, because we know that we are a high incidence region, probably some of the highest in the world. As has been shown before, that HCC occurs at a much younger age, and it definitely will then occur more often in mothers during their reproductive years. The risk factors for HCC that affect fertility in high-income countries are, as we stand now, they are increasing, but they're still less prevalent in sub-Saharan Africa. And importantly, in the absence of cirrhosis, fertility is not affected by chronic HPV infection. that is the major etiological factor on our subcontinent. You also look at total fertility rates. That is much lower in Europe and or high-income countries than in Africa. You can see they're almost 3 times higher. And if you calculate the total lifetime pregnancy duration, then for females, sort of the median would be 44 months of pregnancy during a female's lifetime, where she will have a time where if HCC is present, it will coincide with the pregnancy, and that is compared to only 13.6 months in high-income countries. So it's reported as a rare condition. Less than 100 cases have been reported in the literature. To date, the largest case series was 5 patients. And most of the reviews also include other tumor forms, so not clean HCC cohorts. And pre- and postnatal cases are usually included. So is it a true reflection of the problem? I think if you look at the factors that I've mentioned before, that it's unlikely. There's really not much evidence on how to manage these patients, and there's certainly selective reporting. Another factor that I haven't mentioned is whether one established the cause of maternal deaths during pregnancy. That is, I think, done quite accurately in high-income countries because it's a rare occurrence, and usually there will be a lot of effort to establish the exact cause of death. Whereas I suspect that in Africa, it will just be regarded as another maternal death, and the exact cause of the maternal death would not necessarily be further investigated. So I'm just going to show you our series of patients in a registry that's been same registry that Marc mentioned, a total of 728 patients when we did these measurements, of whom 192 were female. And HCC during pregnancy or in the first year postpartum occurred in 10. So that would be about 5.2% if I calculate correct there. Mean age of diagnosis was, that is in the females. Mean age of diagnosis was 32 years, just confirming that it sort of concur a little bit with the peak. Maybe the peak for HCC is a little bit later, but certainly many of those patients are in the risk zone. So of these 10 patients, 8 of the diagnoses were made during the pregnancy, and only 2 of the pregnancies, and in 2 patients it was done in the postpartum period. I recall the one patient, it was 2 or 3 days after the delivery. And chronic hepatitis virus infection present in 70% of the females. This is just a list of the patients, and you can see there the gestation of when it occurred during pregnancy, anything from 8 to 36 weeks. And you can see also quite in patients that were secretors of AFP tended to be very, very high levels there. And this is what it looks like, and it's really something that you don't want to see when the MRI is performed, that you see the developing fetus, and at the same time, like as in this patient, I think it was a 32-week pregnancy where there was a multifocal HCC in the liver. So how we treated these patients, only one patient was treated during pregnancy, and there we performed a bland embolization. So you should not use doxorubicin if one is if there's a chance for the baby that can be born at a viable age. But we should not add, clearly not tear for radiation, and certainly not doxorubicin as well for the tear. So we did a bland embolization in that patient, and it was mostly just to contain actually more the bleeding than anything else, because it was a tumor rupture during pregnancy. And it often happens when the rapidly growing tumor, and there's some evidence that these tumors can grow quicker during pregnancy, and the growing fetus start competing for space. In the other patients, in whom it was discovered during pregnancy, they were treated only after the pregnancy was concluded. So in total, liver resections were performed in 2. life prolonging treatment, sorafenib or TACE eventually were done in 4, and 4 of the patients went to only best supportive care. And the maternal mortality rate in our group was 70%. 3 patients died within 90 days. Of the 3 survivors, 2 of them have actually have lived more than 10 years. And the fetal outcomes basically a 50% mortality. So just in terms of how we can make things better, prenatal care. So I think it's very important in high HBV prevalence areas that perinatal care should, apart from HIV screening, also include HBV screening for chronic HBV infection. These patients should be surveyed as all other patients with an ultrasound screening and AFP measurements, and especially in pregnancy with discordant elevations of AFP, particularly before 20 weeks, or disproportionate to the gestational period, and underlying HCC should be excluded. There's a couple of practical points and why there are often delays in prognosis. The common symptoms, and these were also the more common symptoms in our patients: abdominal pain, anorexia, nausea, may mimic benign pregnancy-related conditions, so they basically ignored or treated symptomatically. And then also some of the physiological changes of pregnancy, such as increased abdominal girth, altered liver function tests, and there's also this normal increase of AFP during pregnancy that actually may mimic HCC, and often one would not pay attention to a raised AFP. So just of interest, so maternal serum AFP rises steadily from approximately 12 weeks of gestation, peaks around 32, and then declines progressively towards the end of the term. So you're really looking, if you're going to do the AFP, for a disproportionately high AFP levels, and there are sort of guidelines of what the levels, what would be a normal AFP level in terms of the duration of the pregnancy. When it comes to the delivery, most of the articles suggest that the mode of delivery should be determined by obstetric indications, not by the tumor. That is sort of general guidelines for cancer in general. But one must understand that none of the tumors that are mentioned as the common ones actually grow in the abdomen to the size that HCCs can grow like during pregnancy. And really there, I think one should have a little bit careful just to blindly follow the statements. In some patients, certainly a cesarean section will be less risky for the mother and for the child. So vaginal birth, they say, is recommended when feasible, and the timing really considers the fetal maturity to avoid iatrogenic prematurity. So we know that HCC in sub-Saharan Africa, for the reasons that I've mentioned, is still a very common disease, a very fatal disease. And I think it's very likely that there's underestimation of this problem. And unfortunately, we're still living on a subcontinent where the median survival is less than 3 months, as opposed to most of the other countries, including Egypt, where it's probably 5 or 6 times better than here. So to conclude, there's really scanty information to guide management in these patients. It's likely a bigger problem in sub-Saharan Africa than we think, and one can probably get closer to the truth with some proper modeling. And one has to take in account that one tumor in 50% of cases will actually result in 2 deaths, both the mother and the child. Thank you very much.
Thanks, Ed. Yeah, it's a very horrible situation with really bad outcomes. Are there any questions? Okay. All right. I think let's move on to the last speaker, Brian Moisi, who's our fellow in HVB. He's coming to the end of his time. He's going to be going back to Kenya next year. And he's going to present a case of a young, male patient who's an immigrant from Malawi and that we're currently managing.
Sorry, thank you everyone for joining, and thank you for the opportunity, Marc. I'll just go into the case. So we managed this patient, a 38-year-old male with a background of chronic hepatitis B with cirrhotic portal hypertension. And he essentially presented to us with multiple variceal bleeds, despite compliance with secondary prophylaxis program. So he was on the banding, variceal banding list for eradication, and he was on beta blockers. His fitness was preserved, so he had a good performance status of 0, and his nutritional status was good. He had no encephalopathy and no ascites. His recent labs showed a pancytopenia in keeping with the portal hypertension, and he had total bili of 8, INR of 1.25, albumin of 30. The viral load was still elevated at 9,907 with a new AFP of 320. And this was the imaging that he had during the last variceal bleed. So on the right is an arterial phase, which shows an obviously cirrhotic liver. And if you look at segment 6, there's a hyper-enhancing lesion. There's a hyper-enhancing lesion. And what looks like a central hypodensity that we thought was a necrotic area of the lesion, and a splenomegaly, sorry. If you look at the left of the screen, you can see the distal esophagus with esophageal varices. The cirrhosis is redemonstrated, and you can see there's more washout of the contrast in this phase of imaging. The portal vein is patent and distended. And you can see the splenomegaly and the rest of the portosystemic collaterals. If you look at that cut there, you see non-occlusive portal vein thrombosis, which we thought might represent chronic thrombus. And on the arterial phase, this thrombus did not take contrast, so we thought it was blunt tumor thrombus, but a bland embolus, the thrombus of the vein. So the diagnosis at the time was a patient known with chronic hepatitis B, and his liver function assessment showed a Child-Pugh score of A6. He had a grade 2 ALBI score and a MELD of 9. We know that he has cirrhotic portal hypertension that presented with variceal bleed, and he had that Lyrod 5 lesion in segment 5. And this lesion specifically was 5 centimeters in the widest diameter. And there was a non-occlusive portal vein thrombus that we thought was blunt and not a tumor thrombus. And in terms of the Barcelona clinic classification, we placed him at A, early stage. So just going directly into the table that has been discussed by Professor Bernon. So if you look at where our patient is, starting from the size or the morphology, he has a single nodule, and we know that if you have a single nodule, the size doesn't really matter. And he has preserved liver function with a preserved performance status. So that puts him at early stage A. But if you go down that algorithm, he has elevated portal pressure, and therefore a resection would not be a good idea in his case. So then we go down this algorithm, and the next best curative intent treatment would be ablation. However, the patient has a lesion that would not be best treated this way because it's large. It was about 5 centimeters. And then obviously the next thing would be transplant, and he does fall within the Milan criteria, or if you extend it, even the UCSF criteria would be, he would be within the UCSF criteria. However, his social circumstances may preclude him, as he's not from South Africa. So then he migrates to TACE treatment, to TACE, which essentially is a non-curative treatment. But we also know that he has presented now with multiple variceal bleeds, essentially failure of secondary prophylaxis for acute variceal bleeds. So we discussed this case in our MDT and decided to offer him a TACE, and for the management of the portal hypertension and the recurrent variceal bleeds, we offered him a TIPS. So these are the images of the TACE. And starting from the right of the screen where my arrow shows, where my arrow is pointing, you can see the hepatic artery on the angiogram beginning to demonstrate contrast uptake from the tumor or from the HCC. And on the next image, the Lapayado sits nicely within the tumor, and post-embolization angiogram shows no flow into the tumor. So that was a good radiological result from the TACE. And then the patient went on to have a TIPS, and the pre-TIPS HPVG was 19 millimeters of mercury. And you can see in the first image, the catheter has been passed from the right hepatic vein into the portal vein. And in the next image on the top right of the screen, you see that the image that the catheter has been passed into the coronary vein, and there was a transvenous obliteration of the gastric and esophageal varices. And then the next image shows a deployed stent plus coils within the portosystemic collaterals through the coronary vein. So we were happy with that result, and his post-TIPS HPVG was 8 millimeters of mercury. So that essentially addressed his portal hypertension. And if we examine our patient, essentially he has most of the features that would place him as an ideal surgical candidate, and essentially that would be a curative treatment. So he has a preserved liver function. His MEL score is less than 10. However, he has clinically significant portal hypertension. And when we looked at the imaging, the size of the lesion was about 5 centimeters. It's in the periphery in segment 6. Perhaps a minor resection would be curative in his case. And that obviously goes into the last point, but we can't ignore the clinically significant portal hypertension in this case. And this has been shown to increase post-hepatectomy liver failure in these patients. So just to go back to how portal hypertension and HCC sort of have this interplay and sort of complicate the management of these patients. The first thing to know is that patients who present with clinically significant portal hypertension in chronic liver disease have a high chance of having an HCC. So say a patient presents with a new onset variceal bleed, they should be investigated for a possible HCC. And some of the reasons why an HCC would increase your portal pressure is because of increased arterioportal shunts through the tumor. And in certain instances, when you have advanced HCC, you may have a portal vein tumor thrombus. The second thing to know is that patients with HCC and portal hypertension have been shown to have a poor survival. And this obviously can be attributed to the decompensation of their liver function, as well as complications of portal hypertension, such as variceal bleeding and ascites, and the fact that they may have contraindications to the different treatments that we have available for HCC, that is surgery, local regional therapies, and certain systemic therapies, and in particular bevacizumab and atezolizumab, which in combination have been shown to increase the risk of bleeding in patients who are at high risk of variceal bleeds. So essentially, you can conceive that addressing clinically significant portal hypertension in HCC should improve survival, and this has been shown to be true, and it may allow access to some treatment options. So just looking at it in terms of what the advantages are and the drawbacks. So first thing, obviously, you're able to treat recurrent or refractory ascites, and patients may have increased transplant-free survival. And in patients who it is indicated, tips to address variceal bleeding is a key management step that improves survival. in terms of HCC, patients who are on the wait list are at risk of falling out for different reasons, as we've heard from the previous speaker. And one of them is complications from portal hypertension, and the others obviously include tumor progression. So TIPS should be considered as one of the treatments that should be offered in patients who are on the wait list, who decompensate due to portal hypertension complications. The obvious drawbacks we know are the risk of liver dysfunction, because a portosystemic shunt reduces portal flow into an already diseased liver, and therefore certain patients are at risk of liver dysfunction post this. And then in central tumors, a portosystemic shunt obviously uses an intrahepatic approach, and perforation or access of the vessels through the tumor increases the risk of HCC spread transvenously. And there's been evidence that the patients with TIPS have less effective transarterial treatment during TACE. So we know the obvious contraindications for TIPS, and I won't go too much into that. And obviously in salvage situations, we may not go through the entire evaluation. So the rationale behind or the thinking behind why TIPS may render patients less responsive to TACE is because of the arterial portal shunting that occurs post TIPS. And this essentially increases blood flow to the tumor, reducing the efficacy of a transarterial treatment. The other issue with TIPS in HCC is that you essentially reduce portal inflow, and you predispose the patient to liver ischemia. And if you're going to offer them a transarterial chemoembolization, which relies on ischemia to the tumor and maybe collateral damage to the liver, then you increase the risk of liver dysfunction. Again, TIPS may not be technically feasible in central masses, and it may be difficult there may be difficulty in distinguishing between tumor thrombus and blunt thrombus. So there's some evidence attempting to look at the efficacy and the safety of TIPS in HCC. So this particular study looked at, essentially was a systematic review that looked at several studies. And all these studies essentially were non-comparative, they were heterogeneous and had low level of evidence. But essentially this is what is available because it's difficult to randomize such patients. So the studies were grouped into two. There were 11 that looked at portal hypertension related complications in HCC and whether TIPS was effective in treating this. And the thing is, they did not report on technical failure rates, which is important in patients with HCC, because we've mentioned that if you have a central mass or you have a tumor thrombus, you may not be successful. So they only reported the patients who had a successful TIPS. But in any case, in those patients who had a successful TIPS, there was high rates of resolution of ascites and the same rate of patients that we see in non-HCC, the same rates of non-rebleed is what we see in patients without HCC, so about 70%. The hepatic encephalopathy rates were similar, again, in patients who have TIPS for other indications and without HCC. And stent dysfunction was between 6 and 38%. Interestingly, the stent dysfunction increased in patients who had larger tumors or more central tumors. Again, in the other group of studies, they looked at the effect of TIPS and local or systemic treatment options. And again, it was non-comparative, so it was really difficult to interpret this in the context of patients who have local regional treatments without a TIPS. But essentially, those acceptable complete response rates between 16 to 75%, and the overall survival was 23 to 73 months, which is what we see in patients with without tips who receive a TIS, and the transplantation rates was 8 to 80%. But given the low quality of studies and obviously selection bias, not too many recommendations can be made from this evidence. Again, the other question we obviously would like to entertain is whether tips can be used to sort of control the portal hypertension and improve or increase the patient's safety for a liver resection. So this study aimed at looking at patients who benefited from a curative intent treatment after a TIPS. So it was essentially a case series, and again, very low evidence, a lot of selection bias. But just to look at it, there were 8 patients in total. Sorry, I meant 9 patients, and 3 patients had a TIPS post local regional therapy after they developed an acute variceal bleed. 3 patients had a TIPS for refractory ascites after local regional therapy. And the last group was 3 patients who had TIPS pre-resection. So they had initially been planned for a resection, and then they had the TIPS to control portal hypertension. But during the planning for the resection, the procedures were abandoned and they opted for other local regional therapies or a liver transplant because an organ became available. So again, very limited evidence that can be, and very little can be interpreted from this. However, what we can say is TIPS is safe in the management of patients with portal hypertensive complications, and those who are in the waiting list can be safely considered for TIPS. And essentially, we should individualize patient selection for treatment. And what I could gather from the limited evidence that we had on this topic is that in patients who it is indicated a TIPS should not be should be offered, especially those with portal hypertensive related complications, despite the fact that they have an HCC, because the complications essentially make the survival less or decrease their survival. And then patients who have TIPS have a generally better overall survival, especially if they've had portal hypertensive related complications and with an HCC. And then in some patients, local regional therapies may be safe post TIPS. And at the moment, there's no data to support liver resection post TIPS in patients who have portal hypertension. Essentially, we should select our patients well for these treatments, and this is best done in an MDT. Thank you.
Thank you very much, Brian, for a nice presentation that I think also raised a couple of questions. Any questions from anybody in the of the attendees? I can't see anything in the chat. Brian, just a few comments and questions. I suppose that this patient, before we did anything to this patient, that we controlled the virus, that we put the patient on antiretrovirals. What done, and in which sequence would you administer the drugs?
So, Prof, he already was on Truvada for the chronic hepatitis B. I think it was initiated after the admission for the variceal bleed. And I'm not sure if you've asked the sequence of
Which drug would you give first, and then what would you give for maintenance?
okay, so in our institution, we offer them lamivudine in the acute phase, one to lower the viral load quickly, and because we are worried or we're not sure whether the patient has a renal dysfunction at the time of presentation. So we avoid tenofovir until we establish that the patient is fit for that. And yeah, we maintain them with tenofovir or a combination of the two.
So, I mean, this patient clearly had cirrhosis, and we can see it on the CT. But the other thing we shouldn't forget, and especially patients that come from that part of Africa, is they often have bilharzia uh, infections as well, where we get a pre-hepatic component of the portal hypertension, and I suppose we've tested for that in this patient.
Yeah, he had a schistosomiasis serology.
No, I mean, I understand what you said, that there's no data really to look at resection after TIPS in a patient like that. And we know that we are restrictive with TIPS in patients with bad liver function because of the risk of encephalopathy. And if you take in consideration that the reason why we don't like to operate on cirrhotic patients is because their future liver remnants have to be very large to cope. And a resection of part of the liver, even if it's little, may put a patient at risk of encephalopathy due to liver failure. And now we actually have a slightly additive risk of encephalopathy. The patient with a shunt, although this patient didn't develop any encephalopathy, and then operating the liver, you may run into problems with that. So still, I think a little bit of uncharted waters we're on, but the plan with this patient, as I understand it, eventually is to do a resection.
Yeah, that's essentially it's the same thing we've been talking about, how we are stretching our indications for treatment because we don't have certain options. Say for in his case, a transplantation would be the ideal treatment, but he doesn't have access to that. So I think that's the situation we're in, and essentially is super selected as well because the tumor is in a special peripheral place, and he's quite fit and young. So
Yeah.
see how it progresses.
I can't see any other questions. So if there are not other questions, we can conclude in time. So I think Marc is still with us. Thank you very much for the presentations, Brian, to you as well. And also thanks to the echo UNM and echo India teams. The recordings of these talks are available on the Gastro Foundation website. And then also, not to forget, thanks to our sponsors. And then, as I understand it, the last meeting will be the next one for the year, and that will be on patient blood management at the same time next week. Thank you very much. Have a nice day.
Thanks a lot. Cheers. Goodbye.